Hello everyone, this is Bob Browner with our first update of the cancer screening project with the federally qualified health centers across the state. So some preliminary numbers, basically this is a bubble diagram we like to use, which basically shows the 6 clinics that have sent in their data to us so far. One where they are on an absolute percentage base, but the absolute size of their clinic is also relative to this bubble. So obviously this is a very large FQHC, this is a very small one. Kind of helps put things into perspective in the size. We have a lot of variation between the FQHCs in Nebraska, not only in size, but varying different demographic profiles. Quite a bit of variation in quality, although I'll caution you that when we usually start these projects, we find that a lot of the data initially is not real. And as an example, this is last year's data for all the clinics that participated in the Lincoln and the surrounding areas. And some clinics, initially probably looked really bad. Some actually even had a 0% because their EHR was that messed up. A lot of times in the first 3 to 6 months, you'll see massive improvements because people clean up the data and you find out where the real numbers are. And so with the initial round of data, I think there's a lot of what I would call messy EHR data. So I would not read too much into those numbers. And even though you've all been submitting those numbers to HRSA for years, they may or may not be actually that accurate. One thing I want to talk a little bit more about, though, is after visiting with all 7 FQHCs, what we heard over and over again is the primary barrier is screening for colorectal cancer screening, frankly, the lack of health insurance coverage and what that's doing. We went back and worked with one of the clinics and asked them to pull their data based on a couple different demographic things, insured versus uninsured, race, ethnicity, and found out that really there weren't that big of differences on breast and cervical cancer screening, but for colorectal cancer screening there's a dramatic difference. And as all of you guys were saying when we were at your clinics, the big difference is the fact that people who don't have health insurance don't get screened. Yes, getting people an FOBT, it sounds nice, but you know what are you going to do with the positive? So I think it kind of creates a defeatist attitude for good reason, meaning if I'm going to screen somebody and I can't do anything about it, why would I even go to the effort? And basically what we found over and over again is that insurance status is the main obstacle. This is not a unique thing. This is actually an article from last month's Health Affairs where they actually looked at what changing the Affordable Care Act made a difference with cancer screening, and colorectal was huge. Why? Because they fixed the financial barrier. There weren't big differences made based on breast cancer screening and other things they looked at because the out-of-pocket wasn't such a big deal. But essentially, if you look at the summary, the ACA effect on colorectal cancer was huge because of the decrease in out-of-pocket spending. Because colorectal cancer screening is out of the price range of most people unless they're pretty wealthy. And for your population, even more so. And that explains the differences. So what are we going to do about it? I think some people are frustrated because the programs out there aren't very good at covering this kind of thing. While there's a couple options, yes, right now the Every Woman Matters program has some eligibility issues. It doesn't work exactly how we want it to work, but that doesn't mean it can't be changed. And so I think one of the solutions is saying, let's use this data to see if we can change the Every Woman Matters program to actually fix the need that we're finding is the most needing to be addressed. We can use this data for grant funding. There's CDC grants, HRSA grants, Cancer Society, a lot of other things that you can do. The other thing is even local solutions. So here in Lincoln, for example, the County Medical Society has set up a program so that people who do not have health insurance, several of the facilities have agreed to waive the facility fee, and then they'll pay an endoscopist at Medicaid rates, of which grant funding will cover a portion. The patient covers a little bit, but we can get a colonoscopy done for a patient for about $250 to $300 with a good chunk of that covered by grant money. So that's a partial solution, and there may be other ideas. So how do we get there? Well, to do advocacy, what we need are hard numbers. You can't do everything based on an N of 1. I had this one patient. We need to say how many patients don't get screened. If we can get data similar to that I just showed you from multiple FQHCs across the state, stratified by race and ethnicity, we can show exactly how many thousands of people do not get screened because of this. That's a hard number we can take to groups and try to get our programs changed. So this is just one clinic, but if I can produce similar graphics like this for multiple FQHCs across the state, this clinic gave us approval to look. I have 2 other FQHCs that said yes too. I want to see if I can get at least 5 or 6, run similar numbers, and then I can take those numbers to people and we can do something about it. And not just me, a couple of us. So I think next steps, essentially, we need your approval to look at quality data via subgroups. Is it part of the DHHS contract? No, but we should do it because it's the right thing to do and it's going to help us solve our problem to get more people screened. We'd like to set up some follow-up discussions with HCAN and or DHHS or the Cancer Society, various folks to say, okay, what can we do to fix this? We know what the issue is. Once we've got hard numbers to quantify the issue, that is what we can take to folks and try and get the problem solved. So So what I'm asking for you guys is to give me approval to work with you to look at your cancer screening numbers based on these subgroups, and send any questions to me. And I'll be follow up. We'll be probably talking about doing some site visits here in the next month or two, which we can do some more follow up there. I'd like to set up a meeting with HCAN, and also, of course, we'll talk more about the HPV project that some of your pediatricians may be taking on in the future. Thanks, and let me know if you have any questions.